I give on lectures and I was a whole day with them. If you can help them out with surgeons, kind of the ones
The
who need.
Giuseppe, the Italians are very helpful. There's a company, I don't know, you probably know them, Emergency from Italy that are in Afghanistan with Joey
Mm-hmm.
and are really helping, and they're respected and do good.
Stuffing some hospitals and
Exactly.
I'm trying to. I reached Majuba. She says she's almost ready. But
Yeah, I reached out to Kevin also. If not, we can start with Joey if you want.
yeah, what conference you guys organized in Afghanistan? It's like a general neurosurgery conference.
It's a neurotrauma. Yeah.
Okay.
Yeah. So a lot of challenges actually here, like a lot of, but we manage it. I probably just send you the link and thanks for tomorrow because going to have it.
Your connection is perfect.
Thank you. No, because I make sure everything is all right. I just finished one task. That's a jump here. So because I think it's important as well to catch this one. So I think these people are helpful when I let us show them the ways to do things. And I said I need high-speed internet, so they cut off from one side, they push it in the side. So it's look good.
That's great. I wish I could do that with my kids.
Yeah, I was impressed as well, like sitting in Afghanistan, and the connection is not good.
Yeah, it's perfect. It's perfect.
Yeah.
Yeah, yeah. Yeah, well, God bless you, man. You're doing good stuff.
I think once your intention is really clean and clean, so things getting everything piece put part in a part, things are getting on the right way.
Good, 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 very good. Franco Cervide was supposed to be with him, Giuseppe, and the emergency crew, and Tariq Khan was supposed to be in Afghanistan, but they had trouble with permissions and visas and so forth. So Joey went.
Yeah, we had invited Dr. Khan. He told us he had another engagement today.
Yeah. Kevin is texting me.
We're going to wait a couple of minutes just to give people the chance to.
Oh.
Yes. Hi.
Hi, good morning.
Good morning. Good evening.
Good
Hi.
evening.
In Kinshasa right now, there is the African Continental Congress. So it's
Oh,
been like 24 hours without sleep, but it's okay. I'm going to
sorry
hold
about
myself.
that. Do you want to go ahead and check your slides quickly so we can, once
Yeah.
we make
Yeah.
sure your slides are okay, then we can go ahead and get started.
Yep. Hi, Ali.
Good morning. Good morning. How are you?
Yeah, nice
Good
to
to-
see you.
Good to see you too. You remember
Hi,
Joey?
Jawed.
Hi, Maju. How are you?
Fine, thank you. Nice to see you guys. Wow.
Good to see you too.
Okay, I think yes. I'm sharing my screen.
Yeah, we can see your slides very well. Your connection is perfect.
Hopefully this will stay like this.
Ali, I think we can go ahead and get started.
Okay. You want to introduce Majuba?
Yes, welcome everybody. This edition of the monthly webinar of the Cerebrovascular section of the World Federation is on challenges and opportunities around the world. Dr. Ali Sultan from Brigham is in Boston, is the co-moderator of this symposium, has been a leader really in trying to bring together the world around cerebrovascular care. And the first speaker is Dr. Butar Bush, She's from Rabat, Morocco, and she's been and she is currently a member of the World Federation Cerebrovascular Committee. Dr. Butterbush, the podium is yours. Thank you.
Thank you, thank you, thank you, my friends. So I am here to talk about how we can and how we did it, implementing and trying to implement endovascular neurosurgery in Morocco, challenges and opportunities. At the first, I need to talk a little bit about the context of vascular neurosurgery in Morocco. It's been practiced more than 40 years now in university teaching hospitals and in some neurosurgical private clinics all over the country, mostly by senior neurosurgeons, not much, very much, not a huge number, and also in places where we have neurointensivists and specialized nurses and microscopes and settings of setups of angiography. And we all know how we face some challenges in training neurosurgeons in general for this very demanding field that is neurovascular surgery. Evolution of endovascular techniques is faced with the problems of the cost and the difficult access to the devices, and also with the special thing in our continent, but also in Europe, which is the organization of residency training programs, whether it is a neurosurgery program or a radiology program. In the same time, interventional cardiology and peripheral vascular surgery are way more developed by these organ specialists. So, in my department, where I was born, let's say, where I started in 2001 and where I still work, that is the Department of Neurosurgery of the Hospital of Specialties, Neuro-Ophthalmologic Specialties, that has more than 40 years now, is known, this department, which is mine, is very well known for continental leadership of Professor El-Khamlishi and his all the professors in the field of vascular neurosurgery. But in 2006, when I was I was a fourth year resident, and I had already spent 5 years in neurosurgery. It was a turning point in my career, but also in the whole settings in our department, since I went to France at CHU Dijon for a 2 years fellowship under the supervision and the mentorship of a professor of neuroradiology, that is Professor Frédéric Ricolfi, and a professor of neurosurgery, that is who is Jean-Louis Sautreau. So there was an agreement of the two of them to train me and in how to do intracranial aneurysms endovascularly, and also some AVMs and dural arteriovenous fistula and some interventional in spine, while never letting go the knife and the microscope, let's say the microscope. So at my when I came back, I had the position of assistant professor, and I had already spent 7 years in neurosurgery, just as in the residency training programs in the US. So in 2009, a first aneurysm was coiled in neurosurgery and in our settings by myself and other colleagues. And this was actually only 18 years after the first Guglielmi detachable coil was put in an aneurysm in 1991. We can think of it as a great deal of opportunity, as we can think of it as a lack of let's say a bit late, being a bit late as developments are going on. So later, some other units developed, and until now, up until only less than 10 neurointerventionists are in the country. So there is a growing need and interest in this endovascular neurosurgery, and in reality, industry gives us the opportunity to have more devices, same as in cardiology and vascular surgery, but way less. Actually, the concept of endovascular neurosurgery in Europe is kind of awakening. So we talk more of dual training, hybrid neurosurgeon, neurointerventionist, endovascular neurosurgeon. And some countries, as you see in this map, are allowing the training of neurosurgeons, whether they are local neurosurgeons, but very, very infrequently local neurosurgeons, but they train neurosurgeons from all over the world, from Latin America, from Africa, like myself, and from other parts in the world. But they are reluctant and resistant to the idea to let the local neurosurgeons develop these settings. But in USA, Japan, China, India, South America, there is a high level of allowance to this dual training and hybrid neurosurgery or neurovascular surgery. The legitimacy of this awakening comes from the growing body of the mechanical thrombectomy cases that are saving lives, and also from an evidence consequence that is the better outcome when complications are managed by the same operators. You can find even in the website of the European Association of Neurosurgical Societies, surveys, and here and there some ideas about the position of endovascular neurosurgery nowadays in the neurovascular setup of neurosurgery. You can check at the European site. I'm now going to talk about the trajectory, my trajectory, and the trajectory of how endovascular neurosurgery have been implemented. I have to say that I was already meant to be a vascular neurosurgeon, but then the idea, so this case, for example, is the case from my department from, I think from only three months ago. This is an ACOM aneurysm with septic vasospasm, and you can see here that we go about the sound, maybe the sound is, yeah. We go there and we try to put the clip very, you know how we are when we are close to the point where we put the clip to the neck. We apply the clip to the neck. You can see also that we have other clips, although even though the A1s are very tiny, but still we need some security. So in my hands, I need to always put 1 or 2 clips in the 2 A1s to secure my clipping and to go happy with the results at the end. So you can see that the aneurysm was clipped. And to another case, also 60 years old women, WFNS2, ACOM-A aneurysm. This was sent to me for an endovascular treatment, but then I found this a little bit difficult for an endovascular safe treatment, and then I asked the patient and her family to do a clipping, which was successful. And here you can, from the rare cases where I did an angiography, an immediate angiography to assess the safe clipping and the good clipping. And here you can see the clip and the 2 aneurysms done. Here was another case sent from another hospital where a neuroradiologist tried to do this tiny aneurysm with just a coiling, a regular coiling. It was sent to my hands so that I can do something, but I preferred, I didn't have all the devices I would have needed to do a flow diversion or something like this in this young woman that has bled only a few days before with this blood blister-like aneurysm. I was happy. I could put, as you can see here, the clip between A1 and M1 and just go home. This patient had a very nice course. Here you can see another case, very challenging case with a very tiny aneurysm. This aneurysm with a vasospasm in a patient that was sent at day 2 post-bleeding, and with the 3D DSA we could see this. So I I didn't have at that time any stents, any flow diverter, so I went surgically. I wanted to go surgically, so I was aware that there would be some problems with the anterior. I always do my angiographies myself, and I do the CT scan. So I wanted to. Yes, I had see where is the aneurysm anatomically with the anterior glenoidal process. So I knew it's going to be difficult. I went there, and I think it was this case. I could classify it as this case. So I asked some help from other seniors, and it was not easy at all because this aneurysm really was very fragile. So we went back to the endovascular suit, and as you see here, we could put these stents. That is an Elvis Evo, and put the microcatheter, as you see here, at the level of the aneurysm, and I could put a very tiny coil, and that's allowed definitely occlusion of the why they are not working problem. Okay, another case is this case where I had a fetal PCA ruptured gate, and then I could do it using coiling, and I was happy that the course was uneventful. In this case, also with some vasospasm, I prefer to go endovascularly whenever the patient is also insisting on doing it without opening the head. This is also a concept in our settings. People, they don't want the head open, so sometimes when we need it, we do it. But when we can do otherwise, then we can do these cases. This is another case from another woman postpartum, and there was a very huge vasospasm. I could put some coils here, and then I had these 3 posterior cerebral arteries, and the patients did very well after some days in ICU. This is another case also with stents that could be done with coiling and stent remodeling of the neck. This is another. This is just from last week, just to see that I use very frequently balloons, more balloons than stents, because I feel more, less invasive. In this case, this aneurysm was really comparted 2 times in one deep. Sometimes I don't have the exact measures of the coils, so I need to compartment my aneurysm in 2 compartments, and I can achieve this level of occlusion that may be classified as a Raymond class 2. Sometimes when we have hematoma, I can occlude also my aneurysm and then go for the hematoma. Even though I prefer in MCAs, I really prefer to go surgically. This is another case of a vertebral artery pica aneurysm that was coiled by myself 3 years before she came with this recanalization. So we went for a double flow with the baby Vista that is from Balt. And at the beginning, I had a very short. That's the lack of devices. I don't have much. Usually for flow diversion, I only have 2 to 3, and I have to have the exact measures before I ask for a flow diverter. So I went for a short, and then I need another one. And this is my control just a few days ago. Another case was a case of multiple intracranial aneurysm. With this case, this woman had this little aneurysm and this one. So we went for coiling here, and then when I went for coiling here without the balloon, then I had this coil migration, and I had this large vessel occlusion at M1. I went with a solitaire stent retriever, solitaire X, and I could save the patient from being hemiplegic, knowing that this patient was not even, this patient didn't bleed earlier. So I was trying here to show that after taking out the thrombus, I had a very nice M1 at the angiography, at the control angiography. Okay, now a nice MCA. Then I sometimes also I can do this mechanical thrombectomy, even though this is not my frequent job. So also we deal with the fistulas. from like this one, where I had to put onyx in this in the fistula side, and I achieved a very nice occlusion of the fistula, and the patient was able to recover because he had a dementia-like syndrome with a cognitive impairment from a long time. Also, some AVMs can be treated. Here you can see the branch given, inferior temporal branch given this. And then after onyx, this 22-year-old man was able to occlude his AVM using onyx, and he recovered very well. So this is, as you see here in the control, very nice postoperative angiography. In general, in our settings, we know that the best indications for microsurgical clip-ins are also probably the best indications for endovascular treatment. We know that the wide necks can be remodeled using balloons and or stents. We know that flow diverters can be an option even in subarachnoid hemorrhage cases off-label. We know that intrasaccular devices sometimes make it easier, even though it's not yet registered in my country. The web device is not yet registered by the company. And we know that the learning time in endovascular surgery is shorter than in microsurgery in general, and that the bypass surgery is not a routine everywhere, but that the cost of endovascular devices is still a barrier. But this is not the only barrier. Actually, the lack of resources of trained doctors, the opportunity of training, and is in contrast with the growing enthusiasm of neurosurgeons with this technique. And reality also is that more devices are available, and this is an opportunity to show that it's complementary. This work in endovascular neurosurgery, it makes people love to go endovascularly, but also exovascularly, let's say, and also endovascularly, because they more know about the organ and the pathology than the devices. This is an opportunity for every neurosurgeon who loves neurovascular surgery to go out and in. And today we are 2 neurosurgeons in Morocco. Really, that are officially practicing endovascular neurosurgery, and the industry is providing us with the devices as much as they can, as much as we go to some conferences to be updated with the new recommendations and the new devices and the new things. I think in what you can find in 2024 in neurosurgery is this neurosurgical endovascular credentialing in Europe and the United Kingdom for the complete. This is very nice. This is an opportunity to be a very competent neurosurgeon, complete neurovascular surgeon, either endo or exo or microsurgeon. So in conclusion, endovascular neurosurgery is a major advance in neurosurgery, efficient and safe solution for a better outcome to our patients. And there is a constant and growing need in our settings for practicing and for training more young people. And thank you for your attention.
Thank you so much. What a beautiful talk, and your career trajectory and your bravery in being one of the first to bring a new technique and develop an entire continent. It's remarkable. I wanted to sort of ask more of a general question about expanding and bringing these abilities to different parts of that may or may have the resources. One of the central points of this growing interest in expanding microneurosurgery is that financially it's a better option to train developing in parts of the world with microsurgery because the cost is less. The techniques are more durable, there's not as much follow-up and so forth. You having been able to be a champion in this, in both sides, I wanted to ask your idea about what you think is one more efficient to expand and give capabilities, and what's more impactful, and how you think about that.
You know, we neurosurgery, as everybody knows, is not an easy is absolutely not an easy profession, an easy field to live in and with. So you need passion. This was only my passion. This was only the mentorship I had from an experienced vascular neurosurgeon, that is Professor Al-Hamlishi, that said to me at the beginning when I said, wow, these aneurysms are really, this is the most thing we can, I mean, you know, when we are 23, 24, we start internship in neurosurgery, and then you think about these things like a big achievements. He said to me, future is endovascular. You go read about this and come to me in 3 months and tell me about it. I went there. You know how I came back? I came back with this name, with the name of Giuseppe Lanzino, because at that time he was in a Mayo Clinic, and I even remember. I don't know if he remembered this, but when I met him in the Congress in the World Congress in Marrakesh, I said, "Oh, this is you, Lanzino. I have been reading your papers. This was this was in 2005, so it means it's 20 years. I don't even know if he remembers because there was so much people. So maybe Lanzino remembers, but I don't know. So I was reading, and I was fearing something. I was fearing that somebody would say at that time, 20 years ago, I'm not anymore a surgeon, a neurosurgeon. I'm something, let's say, whatever. Well, you know, something. It's like you are not a neurosurgeon anymore. So I faced this kind of these fears, but now more than ever, I can tell you, when I went to this anatomy training, to this endovascular training, to this, all these vessels, all these arteries, and I felt more confident when I came back immediately. I didn't have much cases. I knew I can do it. I would do one case in a month or in 2 months, but I was very, very attentive, very concentrated when somebody else was doing the aneurysm. I mean, my mentors and myself. And I remember in 2009 when I came back, this was the time I did also a couple of cases in clipping, where not complete. You know, when you start at 29, I was 30. I think I was something like this, 31 or something like this. I was not completely confident, but still, knowing the anatomy, knowing you have to be mentored anyway. So completing this path, being passionate, being fearful of complications, also being in updates. I also always do some a week of let's say immersion week somewhere in my friend's hospital in whatever, in France or something, to know about the new what is new, because it's so much is going on. So I think today people are seeing that they can refer aneurysm to this person, to this let's say hybrid neurosurgeon, without fear, knowing that he can do whatever is best for the patient. And this didn't come out of nowhere. This came because there was results. This came because there was so it's really I think today I think people are they want this. Everybody wants to do endovascular. Everybody wants this. Every neurosurgeon wants this. They just don't know how to do it. I think today how they can do it is just come and watch and be in a program. I don't have a program. We don't yet have a program. The other two neurosurgeons that have been able to do what I do was already grown neurosurgeons with the position of associate professors, and then they asked me how we can do it. They had maturity. I started young, but they started later on in life, but they are doing good. I mean, maybe they cannot do very complex cases, but they can do, they can save lives. They can do mechanical thrombectomies. They can do an aneurysm that is bleeding, that cannot be. So I think it's you have to be convinced first. You have to be convinced, but things are already there. Devices are there. Some people who know, I said it's less than 10 in all the country, but people are there. I think neurosurgeons cannot really, for now, they can not work together with neuroradiologists because this resistance that the job is going to be taken from them. But I believe if somebody knows how to do it, to do a good job, then the other things are going to follow, and the other mentees are going to be just amazed how they can help people.
Thank you. Thank you. Very, very insightful. Giuseppe, any?
No, it's been really impressive, and I do remember talking with Marrakesh. Was a wonderful meeting, great setting. So congratulations, really, you've gone a long way, and it's a great example for younger colleagues. As you said, with the passion and conviction. And the other thing it's important is to be persistent, to work every day through the obstacles,
the difficulties,
and not to be discouraged, and work, every day toward that goal. And the cases that you have shown, and it's just a great example of what a modern neurovascular neurosurgeon is. And we all have faced the same challenges. As now it's a little bit less, but when we were starting, not only the fears, we were accused of not being neurosurgeons anymore. And you would hear things, if you think opening the head is bad, then you should not be doing neurosurgery, stuff like that. But it's, as you said, it's about the results, and it's about being open-minded. And there are many cases that where microneurosurgery is by far the best option.
Exactly.
Thank you. So in that, we have a number of things, most of them, congratulations from Paraké and Mumbai, from Dr. Bhatti, from Dr. Ismail, from Dr. Azazi. And I think Dr. Bhatti's last question about the message to the world and places where neurosurgery doesn't support it. I think what you've displayed here, the bravery, the passion, and the unwavering dedication, I think gets you that. I think maybe we go. Thank you so much, Juba. So good to see you as always, sister, and just wonderful to see your work continue to develop. I would like to now introduce Dr. Mohammed Jawed. My interest in global neurosurgery is I'm a vascular surgeon, like many of you, and sort of very, very focused. It's my interest in this is because I am from Afghanistan, and I've always thought about it ever since I was a child, having had to leave and be displaced from my home, and have always been a part of my identity, a part of my compassion, a part of my feelings, a part of who I am. And Jawed is a neurosurgeon in Malaysia who went through the similar stories did in Malaysia, practiced neurosurgeon. Just said something earlier that really resonated with me, and that is to say that when your intentions are clear, when you're trying to do things for the right reason, which is sort of a way Muslims sort of say, good things will come to you. Good things and the right things will come to you. And Jawed is that. He's an angel that came into my life and we've done some beautiful work together. He's right now in Afghanistan. He flew in a few days ago. He's assembling the first Afghan Neurosurgical Society conference. He was supposed to be there with an Italian team and Professor Servade and Professor Khan. So he is the guy doing the work, and he is a charismatic, intelligent, driven human being that just does amazing work and does it. That doesn't just talk about it. So my brother, please take the stage from challenges to solutions in Afghanistan.
Thank you, Ali. Thank you very much. I hope my voice is very clear because I'm talking from the middle of mountain. Actually, now I'm sitting in my Afghan like costumes, and I just get the rooms and I provide the internet. And thank you for this opportunity to give it to me. I'm getting a little bit shift gears from cerebrovascular. It's almost similar to thing. I think the concept is the same. The challenges, cerebrovascular also have a lot of challenges. I'll get it into the challenges from to have it. I mean, all these least developed countries and challenges beyond that how much we can go and help them out. So currently I'm in Afghanistan, Kabul, and basically tomorrow we're going to have the first neurotrauma symposium. I'll invite all of you to come and we'll have it. So basically the topic I given to you, the solution and the challenges. So in spite of the fact Afghanistan is one of those countries been involved for the past 40 years in war, there's plenty of challenges, but the people still resilient here. And I'll just get the very fat kind of challenges that we have here. And this challenges, basically, I put it in term of basically team building and networking, challenging in term of capacity buildings, medical educations, challenging in term of instrument consumable in this country. And the fourth one is mentor and mentorships. And the fifth one is role of women. Actually, this is where the pillars, and not particular neurosurgery, I will put it in healthcare, which we have it currently in Afghanistan. Actually, we are facing it now. So basically, I'm not going to talk about challenges, but I'm giving a little bit of solution as well. So if you look into Afghanistan, it's a landlocked countries. In the middle of the thing is landlocked countries with 33, I mean, officially 36.2 million, but unofficially 32 millions. The GDP, gross domestic product of Afghanistan, is 17.3 billions. Actually, it's a little bit improved from the one I did a similar talk in Boston in 2022. Basically, it's improved from those, according to World Bank, about 600 per capita. And the health and education, this is one of those two sectors, actually, I can see it being the most it's affected part in this countries, in spite of the fact billions of dollars because of this international community was spent in this countries, almost like $2 trillion spent, but still it's remaining the same. While the withdrawal of international communities, I will say that those who was here in 2021, they left Afghanistan's behind. It's almost not if 100,000 of health professional doctors was there. They evacuated. Not only they went themselves, but they take them all this very good people, excellent people with them, and the huge brain drain was there. So there's isolation in terms of diplomatic. Afghanistan have challenges in diplomatic ways. They're not getting recognitions right now, and there's a lot of hassles for us as the professionals to mobilize the youngsters to go for some short term of trainings, fellowships, and courses to go on. It's very difficult for them, and difficult as well being faced in terms of equipment. Profile is knows better than anyone else, like how much difficulty we have if we bring the equipment to the centers that we require to save someone's life. It's a lot of challenges we're facing, and as well as if you look into the female in this sector is also significantly the role of female doctors drops. Most of them evacuated. The university is now closed. So all of these challenges basically we're putting into together, and we're looking for them to find a solution. So as usual, I'm having a travels. This is a little of my story. Start from the Kenya, and subsequently from Kenya, I just shifted my goals toward to Afghanistan. So I do have, like today's, like it was 2 days ago, I had a field trips to one of the Italians, non-organization NGOs called Emergency Hospital. I just visited them up and we had a good kind of communications. They are a trauma center there, almost being in Afghanistan for the past 21 years. And their lack of neurosurgeons, but we're going to find a way to bring a neurosurgeon to them. So this is one of those hospitals I visit back in the past, and basically there's a lot of huge challenges. Now, last time was challenges from equipment, now from the manpower as well. There's a lot of challenges. So we do have a lot of basically communication among the surgeons, doctors, and providing for them as a webinar, seminars. And as well as we're getting engaged officials, Afghan officials like ministers, Minister of Health, Minister of Education. And because I think it's make easier for us when we send the equipment to the country, basically go. The challenge, number 2, I can call it the capacity building in medical education. So what we thought, the COVID, when they hit, I think it's make a scar, but it's bring a lot of good fortune for us. So they connect to us. They connect us with the community that we can do more better. So what we have done is basically we just like go and give a talk and things. This was the one I went, like there was, women was allowed to come to the universities, but now unfortunately they are not coming, females especially. So give a couple of talks to those universities. So what the internet and the COVID did, basically now we're connecting with 5 to 6 centers in Afghanistan. In those centers in the provinces in the middle of the mountain, we bring them up and we upgrade them, and we have different kind of board meetings, tumor board meetings, research and statistics, and medical education, how to write the publications. So we do have alternative week, each week on Sunday, 11:30, we do have this kind of meetings. And most of our fellows, colleagues from all around Afghanistan, we provide for them high band internets. Like currently I'm talking from Afghanistan. I think the internet is quite good enough for them. So we bring external speakers to come and talk with them. So actually we can see now the things running really well and it's progressed really well on the right directions. So we published a couple of papers about Afghanistan, which in the past was writing by the international communities. It was mostly American when they were here, but now we take the hand in our hands and we just writing down. So I think this part of the story is very important and very interesting for me, I think, which we change a lot. So they call it mentorships. What we have observed first is with this kind of programs, what we have done is basically we train the surgeons, not only the neurosurgeons, we train the general surgeons to do the life-saving surgery in the provinces. So we have a lot of seminars for them, but with the help of basically, this was one of the cases when I was there initially on WhatsApps. They have referred me a case with a really bifrontal contusion, and this patient need the bifrontal craniectomy. What they have sent me, they put the isolate of the bone and they send it to me like that. I said, have you done it? They said, yes. So back and forth, we have to draw pictures and send them. And finally, that was the right sides. We have taken out this isolate of the bone because they were not very used to this. General surgeon was not used to. They're afraid of suprasurgical sinus. They might heat it up. So things get better. So what we did, we went one step ahead, and this was one child we operate through online. So what we have done with this one is this is a posterior fossa tumor, very complex tumor. And the surgeon was there. I just used again some of the basically the gadget application we had, and we operate this child. It was huge tumor. We just like if not 100%, we take out the tumor, 90% of the tumor out. We save the eyes, the hydrocephalus, and everything. The child was in stable location. And this is a fantastic team I'm working with, which is Prof. Ali's one of those really the pillar. I think the strong pillar behind us. I think the guidance of him is fantastic to take us all around to go and do. So after that, what's happening? A magic happened in our things. We come across to get this surgical glasses. This is called smart glasses. It's called Ohana One surgical glasses. It's come into the pictures. So we got a couple of these glasses to the countries, and I went there. I just get some training, and I trained the other doctors. So basically, I want to show you one of those cases that I have done with them. This was a 44 years old females. from Nangarhar province. Nangarhar is its regional hospitals covering 5 million population in the middle of the mountain in eastern Afghanistan. And mainly this ladies complain of severe upper back pains and difficulties in walking with the breast reflexes and positive clonus. If you look in the MRI of this one, it's got on C4, C5, 6, it's a huge lesion is there. And that was a pre-operative kind of things. So it's got very breast reflexes and in clonus. We have it. And this was pre-operatively. She came to the hospital. Basically, it looked very myelopathic kind of gaits and walked, even she could not walk. So with the help of surgical glasses, this Ohana one, what we have done is, I just put the whole thing. This is the view. Basically, I was sitting in Malaysia, the doctor sitting in the Nangarhar hospitals, and we get the same case, the one I showed to you. We operate together, and this is the case. Basically, we have done the case. Okay. And it's so amazing to me as I think the view was so magnificent. Actually, I had that kind of view. So the control of the glass in my hand, I can zoom in, zoom out the glasses. I can zoom in, zoom out the glasses. I can pinpoint basically where to go, how to operate. You have to avoid these things. This was between C5 and C4. I think it was dumbbell tumor. I think schwannoma, one of the schwannomas, they come from root of C4 coming invaded inside. So we went and just like safely, basically we just take out this whole lesions. We take it out safely. And I was having this kind of magnificent, good, clear, and high pixels view while I'm sitting in Malaysia and someone is operating in the middle of the mountain in Jalalabad. So in the past, I would have to say that in the past, basically we're using drone in technology to destroy the house, but the same technology we're using to save life and bring some changes to people's life. So we have taken the tumor out. The tumor is totally out, and we brought this things. This lady, she came after 15 days post-op to the surgical clinic, and see the same ladies come after 15 days again without infection, and she can walk. And she's happy, and she's doing beautifully. She did fantastic. So I think we have done almost this is almost our 9 or 10 cases. We have done different kind of cases. That was a sample I put it out. In terms of consumable and instrument, we do have challenges. We send the first batch of instrument we sent to Afghanistan. But I think there's a lot of more needs to come, and we do have a lot of challenges. Most of our equipment not reaching there, so we find the channels to get equipment to the hospitals while they operate, because mostly, even till now, they're operating with a Hudson brace. Of course, I mean challenges for female. I don't have solution for that yet. Hopefully one day, I think there'll be a solution. We can, a lot of female like Majuba right now, I was so inspired. I mean, the way you give a talk, it was one of the idol to have similar females in neurosurgery to come and help their people. So in conclusion, basically, in spite of all these challenges, of course, we are committed to the field to find the solutions. And we need more, basically, engagement of our colleagues and officials, develop a good way to communicate with our internationals, basically communities, and find a way to bring the experts on the field to give more trainings on the field. It's mean that not they're getting out of the country, the expert come inside Afghanistan to train them. And we have to use the maximal use of digital health platform. I think this is the future, include of AI and all the smart glasses. I think we can do the best. And that was a little bit things I had with you guys to share. And thank you very much for listening. If you have any question, I'm more than happy. And this is this car is actually made in Afghanistan. Despite if it's, I don't know, indeed it's running how fast running was looking really good. You know, if we bring food together, you can develop so much things. That's really made in Afghanistan. Thank you.
Yeah, a lot of special things and special people are made in Afghanistan. Thank you for an amazing and inspirational talk. It was really, really nice. I think the concept of using technology to go across distance, to go across challenges, to go across politics. Politicians and policymakers and sometimes split people. The point of a doctor is to heal, and sometimes you heal a patient, and sometimes you heal a group of people, and sometimes you help bring a component of healing to a beautiful, beautiful country. God bless you for all the work you do. I am behind you. We are behind you 100%, always. So thank you for this. I wanted to touch on one particular topic, which is very, very sensitive, and that is the education of women. And I know that you're in Afghanistan right now, and I just wanted to put two sides to this conversation. And one is in a country that is women's education is paramount to everything that we do, without question. My mother was a MD, PhD doctor. Afghan women are the strongest women that I've seen around. For the international community, this almost seems as a single narrative that if this isn't happening, this is all the sanctions we're going to do, and this is all the things that we're going to do as a result of this. And the unfortunate component of it is that these sanctions hurt the exact people and their children that they're trying to help. These sanctions don't necessarily change political decisions early on, but they do make the poor suffer. They make the children suffer. They make the women suffer. They make the poor suffer. That's one component of it. The other component of it is that after 40 years of war, Afghanistan is a hospitable, kind place, deeply rooted in our religion and our culture, and welcoming and kind like you. After 40 years of war, things are destroyed, and now you're blaming the cough for the pneumonia that was over there, right? But there is hope. You say challenges. I just learned to stop saying challenges and say opportunities, right? Time changes. People develop. The younger generation goes up. Peace, food, healthcare, the calm people that are well-fed, sheltered, don't have bombs dropping on top of them, will change and will improve. It's not quick, but it will happen. So I'm sorry for going off on a tangent. I just wanted to get your brief outlook on the future of our country.
Yeah, yeah. I mean, like Alijan, I'm here. I think we have like one of the top smartest people. They're very, very committed. I think what they need is basically, I think they need the opportunity. I think that's been taken for them. I think now they being close things. So we take. I mean, the as you say, the opportunities. I would not say that the challenges. We take these things to bring it up. I think it's needed time. I think slowly, which we start this program with them, is I think it's coming up, and now we do a lot of those cases not in the past been done here, in terms of neurosurgery, particularly to say we can do it, and those kind of cases been done. So the next thing is we're looking for cerebrovascular. Actually, Afghanistan don't have cerebrovascular in pediatric neurosurgeries. I think we're thinking to look like what Majuba says. The neurosurgeon come to neurointerventions, neurocerebrovasculars. We train them and send them back here to serve the people. So this is the direction we're going, and we are committed to it. And I'm very, very kind of optimistic for that's going to be happen, because the people are resilient and they're open to it, and we're going to get it done. Yeah.
Wonderful. Thank you. Any other thoughts, Giuseppe, anybody else?
No, I just like to say that I'm inspired by what I've heard and in these two talks, and I, would like to know what we can do together to help, colleagues who are working in this environment. And I mean, the work that has been done in the cases that you show, they're just remarkable.
Yeah. Yeah, true. I think what we need is, I think now the world is coming very closer to closer. I do using these glasses, actually the pixel of these glasses and the view, we see that it's looking amazingly, feeling like you being just stood at the side of them. So I think there's no more anymore needs to come and just go there. I think we have to put the technology together to get into that, and we're getting furthermore training. So I think we're looking to that directions, and especially in field of neurointervention, which Prof. Ali has the concepts. I think we can do far. I mean, far away, basically can manage the cases. Can be done if you train, and especially in cerebrovasculars. Actually, Afghanistan have a great need in cerebrovasculars. There's a lack of cerebrovascular surgeons, interventionists, and neurologists. I think this is basically the objective of us to get all those fields, like which is till now being here is mostly they've been doing a lot of neuro traumas instead of to be much more specialized field.
Yeah. I think this is a perfect opportunity to transition to the next speaker, Dr. Kevin Wade. So we actually did send equipment, stents, some catheters, thrombectomy devices into Afghanistan with a special young man who is endovascular trained, Dr. Ashraf Abdali. And we even sent systems that you can plug into the monitor so that we can see it and sort of help guide. We came to Boston, practiced on flow models. But the challenges of starting a system to detect stroke, whether it's from the patients recognizing it, to ambulance system, if it even exists, to scanning and recognizing and diagnosing, to getting to a table. These are system-wide challenges that if they're solved for stroke, then they can be solved for trauma, they can be solved for pediatric emergencies, and really change emergent care in these amazing parts of the world. My brother, Kevin Wade, has managed to do some of this in the beautiful country of Jamaica. He's a professor at the University of the West Indies, and has managed to start the first stroke program as a neurosurgeon, doing endovascular, leading his people to a good way of system building, team building, based on a procedure. I've been influenced by Jamaica most of my life, through the beautiful music. I remember being young and here and a little bit lost in the United States, and somebody gave me a CD tape or something, Marley, and not just the music, but the concept of his words, and the concept of empowerment, and the concept of independence, and the concept of growing your people through love and unity is so evident. You go to some parts of the world, and colonization has demoralized people for generations. You go to Jamaica and you see people look you in the eye and proud of who they are, where they came from, and how they influenced the world from a place where at some point they had levels of oppression. It's a beautiful, beautiful country with beautiful people and a message that resonates around the world. So please, looking forward to hearing from you and looking forward to working with you going forward.
Thank you very much, and good morning, everyone. I hope you're hearing me okay.
Perfect.
Yes. I have to thank Professor Aziz Sultan and Dr. Lanzino for the invitation and the opportunity to speak in this forum. We certainly feel very privileged that we have been invited to represent my hospital and my colleagues and my country in Jamaica, and tell you a little bit about some of the work we have done. We have certainly put a lot of time and effort into building something that we think will meet the needs of our population, not just in Jamaica, but also to provide leadership and guidance for our neighbors in the Caribbean, such as Trinidad and Barbados and other Caribbean islands. And through those initiatives, we aim to build neurosurgery and neurosurgical care across Jamaica and the Caribbean. So I'm going to tell you a little bit about our experience so far, some of the successes that we have had, and some of the challenges that we have faced in implementing our strategies. So I'm going to bring up a presentation. So I'm going to tell you a little bit about how we built a modern neurovascular and stroke program in Jamaica, in the Caribbean, a small island in the Caribbean, some of the challenges that we face, some of the pitfalls that we have. And, you know, I have to praise my colleagues, Mr. Jaweed, Dr. Jaweed, and Dr. Dabush before, for her bravery and for his bravery as well, and for all the work that they're doing. It's really tremendous work. And I'm sure it comes at sacrifice, which is what we do, which is what who we are as neurosurgeons. So I'm a dual trained neurosurgeon in both a vascular surgeon in both open surgical treatment as well as neurointerventional treatments for wide host of vascular conditions. No disclosures for this meeting. This is a picture of the grounds of the University of the West Indies. This is where this is essentially where I developed and did all my undergraduate training here at this university to become a medical doctor. It's a very, very special place. The University of the West Indies, as the name implies, West Indies, Dr. Ali will tell you, as a cricketing nation, represents several countries under one umbrella coming out of the Commonwealth system. And the West Indies, though the West Indies cricket team is perhaps a little bit, not as consistent as in the past, it still holds a very special place for us. So the West Indies represents unity, not just in Jamaica, but in the entire Caribbean. And a lot of leadership comes from Mona, Kingston, Jamaica, to help build the rest of the Caribbean and the university. This is a picture of the Faculty of Medical Science building, which is actually built after I finished my undergraduate program, but does a lot of the undergraduate training now, and is one of the major initiatives of the university and the government to make this happen, to help to bolster our very strong medical student training program. And if you look behind this large building, you have a cluster of buildings, and this represents the University Hospital of the West Indies. So several buildings together in a cluster that form the different departments of the University Hospital. A more close-up view would show the two entrances of the University Hospital. This is our emergency entrance. and two of my mentors in Jamaica, Dr. Carl Bruce, who's our chairman currently, and Professor Ivor Crandon, a really esteemed neurosurgeon in the Caribbean, originally Guyanese, but did all his practice in Jamaica. And he was very instrumental in training up all of us to become strong neurosurgeons. Did some work in overseas as well. I spent some time with Dr. Chris Wallace, actually, Professor Wallace, who, as you remember, would have been the former chair in Toronto. And I met him at Queen's University, and he mentored me. And then did the Drake Fellowship under the tutelage of Dr. Lowney and Dr. Mel Bolton, who's actually himself originally trained in Toronto. So just to situate you, we're well known for our music, but this is where we are located. A small island in the Caribbean Sea. And we put a flag on it so it's easy to find. We are south of our bigger United States neighbor. We are east of Central America, and we are north of the other South American countries. So that's kind of our locale. This is the Caribbean Sea. It's bordered by several islands. These would be the smaller islands: Trinidad down here, Barbados, in this region, Grenada. You may have heard of some of these countries you also hear about in athletics. Similar to how we have our Usain Bolt and Shelley and Fraser Price, they have had some pretty standout athletes as well. So I have to give credence to that. And Jamaica would be the largest English-speaking Caribbean nation, and we sit right here in this location, very centrally located, which has tended to be our role in general. To touch on the burden of disease, so we have some data from the Ministry of Health and Wellness in Jamaica, as well as the Pan American Health Organization and WHO. And we have a very high prevalence of non-communicable diseases like diabetes and hypertension, hyperlipidemia. There has been an increase in the burden of these diseases over the years, quite a significant increase, nearly 15% in 10 years, in fact. Though the age standardized death rates have decreased, the overall burden remains very high. And the total number of deaths reached almost 2,500 deaths in a small country. Our population is about 3 million people. And we're rated as somewhere between a low and middle income country by the WHO or by the World Bank. The age-adjusted death rate is about 65 per 100,000, which gives us an enviable position of about 100 in the world in terms of our mortality figures related to chronic illnesses. So it does tell you that, we have quite a lot to work on. And one of the things that we have realized is that we have a very high prevalence of these chronic illnesses. Every other patient that you see with a vascular condition will have hypertension or diabetes or both. So quite a significant impact of disease. It's an aged population as well, and we expect that up to 17% of our population will be over 60 years old in 2025. That's just next year. The burden has increased. 1 in 3 persons will have some kind of chronic comorbid illness. And certainly persons over, as we mentioned, persons over age 65, 1 in 2 persons, 50% will have hypertension. And what is alarming is that we are seeing a higher instance of hypertension in young patients, in young adults, and they are getting strokes from it. They're getting hemorrhagic stroke, ischemic stroke, quite a significant number. So this is a very alarming trend we have noticed in our population. Our healthcare system is a mixture of public and private hospitals. We have 3 primary tertiary care centers, 2 in Kingston and 1 in Montego Bay. And we have a few other private hospitals which neurosurgeons also go to. But for the major and more complex neurosurgical cases, they have to go to one of these 3 centers. And the University Hospital is uniquely positioned as the final referral center for all the other hospitals in Jamaica. So all the vascular cases, aneurysms, AVMs are referred to University Hospital, either for diagnostic and often for therapeutic treatment as well. They come to the University Hospital. Complex tumors, some complex spine conditions, pediatric cases. So the University Hospital has a very central and leading role in the healthcare in Jamaica overall. And this is the case for other specialties as well, such as cardiac and cardiothoracic. One of the big challenges we have is that we only have a few neurologists. I'm not sure what it's like in other countries, but developing countries, but certainly we only have a handful of neurologists. Unfortunately, as we mentioned, starting the stroke program, Dr. Ali, when I first returned, the big mantra was to start a stroke program, but because of the extensive systemic nature of how to implement a true stroke care pathway, it was the hardest thing to do. As a neurosurgeon, you understand how to get an aneurysm patient to treatment, and even that has challenges. Similar to how we would approach a brain tumor, but there are things that you have a very good understanding of how that works. But trying to get all of your colleagues who are not neurosurgeons along the same way of thinking, I think that was one of the big things that we had to work on. And when a neurologist arrived, and we really got momentum in moving a stroke care, forward. So that's one of the pivotal points in getting the stroke care pathway up and running, is to have the neurologist there and being fully, involved in the process and engaged and helping to drive the process forward. So this part of the problem that we have in the Caribbean and in Jamaica is that we don't have enough data. So though we have a full-fledged university, and it is doing well in terms of its training program, in terms of students, and I didn't mention, we have quite a strong residency program. We have about 12 or 14 residents. We actually have exchange residents with the United Kingdom. We actually started a fellowship program at the University Hospital, started by the chairman, Dr. Bruce, and I actually have one fellow currently who is a fully trained neurosurgeon who's acting as a fellow, who works with me in the vascular service. But part of it is that you don't have enough data. So by design, when I returned to Jamaica after fellowship, I implemented a system where we would be capturing a lot of this data upfront by having a prospective database and registry, so that it would be easier then to look at information, see what our trends are, see what the data says we should be doing or where we should go, where the weaknesses are, and so on. So by design, we started that process from the onset to have a data-driven type of service. Pragmatically, as I mentioned, implementing a vascular program then around, it's primarily the main challenge we have is patients with subarachnoid hemorrhage from ruptured aneurysms, and how do you get those patients to treatment in a resource-limited environment? And then stroke amplifies the time factor several-fold. So if you're trying to get an aneurysm done in 24 hours, you're trying to get a stroke case into the IR suite within a few minutes, maybe an hour. You're really pushing the boundaries of time management across several different departments of your hospital. I think that's one of the big challenges. So the program development, we looked at the ideas and the vision for what we'd want, and we used that idea and vision for how we want to lift and elevate the treatment that we offer to define the goals that we want and set reasonable timelines for how and when we want to achieve these goals. And they are the simple ones that all of us want. We want to improve the quality and standard of patient care across cerebrovascular, including spinal conditions. We want to build out the research and academic framework. We want to include and be inclusive with teaching and training across not just students and residents, but nurses, technicians, the radiographers. We want to have a pretty inclusive suite of treatments around the neurosciences and build a strong, robust, sustainable program. So we started off by doing a SWOT analysis, strength, weaknesses, obstacles, and threats analysis of where we were in terms of our pre-existing neurosurgery program, our residency training program, and what would have been the weaknesses in trying to implement a proper neurovascular program. We were treating aneurysms before. We were some endovascular work was actually started before I returned as well. So credit to what was being done. And then eventually we needed to become a bit more organized and formalize the framework so that we can move the needle in terms of getting the patient treatment done. So some of the tenets of a neurovascular program I felt were, break down the clinical patient care issues. And that will give us a framework for how best to approach these conditions. As you know, stroke TIA framework is different than how you'd manage a ruptured aneurysm, which is different from how you manage an AVM or a fistula, which has ruptured. So those are important things. And obviously there's a way to deal with unruptured lesions as well. And we wanted to incorporate teaching and training and, as I mentioned, research and academia. Some of the good things that happened, even though we had limited resources, through a combination of efforts of the University Hospital, our chairman, Dr. Bruce, the Ministry of Health and Wellness, and some of our colleagues in private side of the hospital, they were able to come together and in unity and give us this a state-of-the-art Philips biplane interventional suite. And this is the cornerstone of our endovascular treatment strategy at the University Hospital. And this suite is also shared with other services. So cardiac uses it, cardiothoracic, interventional radiology uses it. So it serves a very wide purpose and a pivotal role in the hospital healthcare system framework. And it has really shifted a lot of the things that we do overall in the hospital. Now it has helped us to move to a minimally invasive and modern treatment paradigm. The IR team, there's some pictures depicting some of the work. This is actually Dr. Bruce here, observing one of the cases as we worked. This is actually a picture taken from, this is a flow model, this is from when the Civil MT 2020 plus workshop was being done. This was a couple of years ago. They came to help us to do some training and move our stroke program forward. This is a picture of some of our interventional team, a charge nurse, Mr. Obi, and the rest of the gang. And they largely are, super important to making everything work in terms of our patient care, getting patients done in a timely fashion. On the open cerebrovascular side, we have an old Leica microscope, and we recently upgraded to a new RVO8 Leica microscope with with a full suite of integrative technologies, which we're very happy about. So that will help us in terms of taking care of open vascular lesions, some oncology as well. So this was a very good addition to the equipment that we have. So even within the resource limitations, we have found ways to, I think through novel strategies and largely through a unified approach and engaging the various stakeholders, we have found ways to obtain some really important equipment. So I think those are some of the important strengths that we were able to do. But from a bigger picture, not just from infrastructural arrangements, we have to have trained experts and physicians. So as it stands, I'm the only neurosurgeon or the only person who currently is doing a lot of endovascular work in Jamaica. And that has a lot of issues, that poses some challenges for a number of reasons. My current fellow, Dr. Goodluck, we're gearing her up to become a full-fledged endovascular specialist, and she should be heading off to do a fellowship soon, a secondary fellowship to help bolster what she has already learned. And then we hope to bring her back to join the ranks and bolster our team. And we have a few of the residents that we're also looking to gear up for the vascular specialty. Highly specialized neuroimaging facilities are important. The disposables, the catheters, the coils, I think that part is, as was mentioned by my previous colleagues, is one of the major limitations. Recurring cost, very expensive, And most of the patients at risk, most of the patients in our population simply have challenges being able to access this type of treatment. And so we have had to explore novel solutions for how best to make the treatment more accessible to our patients. Pharmaceuticals can also be a big challenge to access. Basic drugs like Integralin or ReoPro, something we have had significant challenges getting pharmaceuticals into the island. Part of it is cost. Part of it seems to be some related to regulatory frameworks. Most of our items we get are from the US. They are FDA approved, and we only really stick to FDA approved items locally. But for some reason, there are some barriers to getting some of these chemicals or pharmaceutical drugs. Staff training, we invested a lot in staff training to help build the program. So when I first returned, we did a series of workshops. I personally did a series of training sessions with the staff, the interventional suite staff, in terms of from starting with diagnostics, going all the way up to interventional treatments for neuro conditions, just to get them up to a different level of function and speed as far as that was concerned. So I feel physician leadership and taking control of some aspects of that will reap a lot of dividends in the intermediate and long term. The more you build your staff, the more your healthcare teams will function, the more training you do. And then you need support from all the stakeholders buy-in. So the hospital administrative framework, the Ministry of Health, industry partners, in different private enterprises, even your international colleagues, as much as they can help, they have helped with a lot with building our program from both academic standpoint as well as in training. They have supported a lot of our initiatives, our yearly neurosurgery CANS meeting, the Caribbean Association of Neurological Surgeons meeting. I've had very, very strong international support, as we will again next year in February, in end of January. And they come to our meetings as well throughout the year. And so that has been very important in making this work. So we developed treatment protocols so that it would enhance the organized approach, because as I mentioned, it's easy for one doctor to say, once they have the tools to go ahead and treat a patient. But when you're talking about something like stroke, or you're talking about a sustainable program, you need an organized approach, a framework for how you're going to bring all the different groups, departments, and heads of departments, etc., together to make it happen in a seamless way for the patient. So one of the ways in which tools I use to emphasize the way patients should be treated is using the simple medical evidence, because the evidence is there, it speaks for itself. And such as in aneurysmal subarachnoid hemorrhage, we know the very high mortality related to a re-rupture of an aneurysm in a patient that presents with good grade subarachnoid hemorrhage. And we know the standard is to have the patient treated within 24 hours. In fact, the same day that they come in, we treat them, or the same night in many instances. And so we push our colleagues and departments to help us to make this happen, whether it's the emergency room, getting the patient scanned and prepped in a timely fashion. We make sure our residents are on top of the patient. We make sure that they're booked in the ICU, intensive care unit, which often has a problem with capacity. So having ICU space to treat patients is one of the major issues or obstacles. And so, we're on the front foot at all times as far as these patients are concerned. It's fairly aggressive trying to get them pushed through and get them to treatment. And we focus on evidence-based management and the guidelines as such. So how we move the needle, you build and develop the care pathways so that the patients can be brought to treatment in a timely fashion, because we emphasize time is brain, and we try and spread the word and make it ingrained amongst our colleagues outside of neurosurgery. And we need stakeholder buy-in for this to work. So the hospital as well needs to be fully on board with what you're doing. So we have a stroke task force, which is headed by the neurologist and co-chaired by myself, that is trying to get the hospital stroke certified. And on that task force sits the heads of almost of all the major departments: internal medicine, surgery, radiology, emergency room, and I believe one or two of the administrators also attend that meeting, so that everybody is on the same page about what we are doing as physicians and what support we need from a hospital standpoint. And so I think that's also very important, that the hospital is on board with whatever you're doing. We have because we are the primary center. We get a lot of the referrals, or all the referrals essentially tend to come to us. We have a system of referrals, so that facilitates some national integration, so that we can get the patients in a timely fashion. And we have very good collaborative relationships with our sister hospitals. And regionally as well, we have strong regional ties and with our colleagues, especially in Trinidad and Barbados and Bahamas, even Guyana. And so, we help to build them as much as we are building ourselves. One of the key parts of this is the neurovascular multidisciplinary meeting, which we have on a weekly basis, and this facilitates several things. It helps with patient management. I think multidisciplinary meetings are the way most centers now offer care to patients in complex conditions, such as a tumor board and other neurovascular multidisciplinary meetings in North America. It also does facilitate teaching and education. Our residents are a core part of this. They are fully engaged. They often present the cases and discuss different aspects of the patient management. And then bringing in experts from different backgrounds, different philosophies, local, regional, as in the Caribbean, and international colleagues who can then help us to guide how best to deal with a particularly complex case. I think these are some of the key things that have helped us to grow. As I mentioned, we had started doing a lot of this, and one of the things that having a database or registry helps us to do is to track our patients, because in our setting, we don't have a strong primary care system, which is one of the challenges in our healthcare system. So it means your patient, you might do a procedure, the patient does fine, but then they get lost to follow. So to prevent that from happening, we have a way of making sure that they get their appointments, that they are coming back to see us in clinic. We often make sure we are managing most of whatever other issues they're having. And that's what essentially guarantees the outcomes. So it's not just to do the surgery, but it's to make sure that they have a good post-operative course, and that when they're being followed in the clinic, they continue to do well. And we've implemented this across the breadth of the vascular conditions. The stroke registry is managed by the stroke neurologist, Dr. March, and that's also another important tool. It's set up in association with the WSO, the World Stroke Organization. So a lot of that will help to organize around stroke, and we aim to analyze that data as we get it soon. So we mentioned protocols and organized framework, buy-in from different persons, the ER, the operating room, the interventional suite, staff training and workshops, residents and students, and a fellow. So this is a snapshot of some of the, you have to write your department, some of the things that we wrote in terms of development of our program and our comprehensive stroke care paradigm. This is a snapshot of our acute stroke protocol, which we have tailored essentially to our locale within the confines and constraints of our system, and we have modeled it on the successes of our colleagues in implementing a stroke care pathways in both Canada and the United States. And we try to build algorithms such as this one for how you take care of a subarachnoid patient, or how you take care of a stroke patient, and model it, as I mentioned, on the systems that have been successful overseas, and try to tailor it to our locale in terms of how best to get some of these issues sorted and achieved. Again, all based on best practice guidelines, best medical evidence. So some of the weaknesses, as I mentioned, is the critical care, the intensive care unit, the high dependency unit, the cost of the disposables, catheters, the coils, the stents that you need, the aspiration catheters. Another downside is the equipment upkeep and maintenance. So in the past, the the government would attempt, or the hospital would purchase major equipments. They would find a way to get it, but then there will be no maintenance contract. And so the equipment would not be maintained. So it breaks down. And when it breaks down, you can't get it to come back up. So you spend, you know, in Jamaican terms, lots and lots of money on these things, and then you can't use it. So now we have shifted the emphasis from not just getting the equipment, but we want them to put systems in place to maintain the equipment so that we'll have it longitudinally. I think that's helpful. Staff retention, as Dr. Jaweed mentioned, the whole issue of brain drain, and unfortunately is another major problem in the Caribbean. And both doctors and nurses, even our technologists, leave in quite large numbers, partly related to seeking better pastures, better better way, better life, without the issues that we face as a developing country. Part of it is a push from our side in terms of, whatever socioeconomic or local issues might prevail at the time, such as violence and crime and so on in some areas. So a lot of different factors are at play about, staff migration and getting some more of our staff to stay. I think we have explored, and we are exploring different ways in which we can, get some of our good staff and keep some of that talent and know-how in our system to help us grow and be sustainable. But some of the solutions that we have found are helpful, as I've mentioned some of them along the way. A phased basis of implementation. So we won't have the resources to implement everything all at once. And some of it you'll have to learn and grow as you go. And so you will know what are the best ways, the best management of resources, for example, is one important part. And we try to get enough persons to form a pool of critical care staff. So these are folks that can help us in the HDU or the ICU to help make those units successful. And we are exploring a variety of different types of funding initiatives to see how best we can, help persons who simply cannot afford or access the expensive treatments, to see how best we can make that accessible for them. And I'm going to show you one example of one of the things that we have done. Join learning sessions, such as the MDT, and we invite a lot of different folks to come to this meeting. So not just international experts, but locally. It's a really good tool that when you bring in other folks in the hospital to show them what you're doing or why it's important to rally around a particular case, it makes makes things a lot better and easier in terms of getting the patient treated. And then one of the other important aspects of things to mention is what kind of joint pathways can you use? Because a lot of the resources are shared. As I mentioned, the interventional suite is a shared resource, which has its own, that idea has its own drawbacks. But certainly the hospital, in terms of being able to afford or bring in something like that, multiple services being able to use it is a big plus, that a wide category of patients will benefit from having that particular technology. And in the same way, stroke, heart attack, subarachnoid hemorrhage, a lot of them have some slightly intermingled underpinnings of how they are approached in modern terms. And so we try to use some of those relationships to see how best we can get funding. We build a lot of strong collaborative relationships. So locally, we have the Jamaica Stroke Alliance, which we present at, we engage them. This is a group of folks which are largely private citizens. Some of them are doctors, and they're trying to find a way to raise stroke awareness. They're trying to find a way to help with funding, etc. And we have partnered with them for the past few years. The World Stroke Organization, as I mentioned, we are on our way to becoming stroke certified. I think we're about over 70% now through the WSO. We are part of the Rescue Registry, and the Angels Initiative has been assisting with training of our staff. As I mentioned, the Mission 2020 Plus, we had a thrombectomy workshop in 2022, which was highly successful and really liked by our local staff. And this is myself with Dr. Sheila Martins, just related to our neurosciences symposium and the thrombectomy workshop. She came as well. She did a lot of the work with us to raise awareness, and both in our hospital and the public space, in terms of what we were doing and the importance of what we were doing and what it means, what kind of value that we would be giving to every single person, their families, their neighbors, their children, their parents, from having these type of treatments available. And then working with us, this is myself, this is our representative from Angels, and 2 internal medicine doctors. This is Dr. Marsh, neurologist, really, really good doctor. And another internal medicine doctor we are hoping will do some stroke training and then return to us. So this data is data that we have put together from the data that we have collected so far. And it's not up to date. I was actually trying to get the updated data for this meeting, but it didn't come through. So this data is a little bit slightly dated, but it shows the overall trend in what I'm trying to highlight. So you can see from the chart the breakdown of cases or the type of cases. And you can see from this breakdown the type of tumors. So the vast majority of treatment initiatives, and these numbers are actually doubled. But essentially, we have a very strong endovascular coiling program, and we have a very strong surgical clipping program. And we find that the ratio has been fairly even over the past few years. A lot of it is based on availability of resources and being able to access expensive coils and stents, etc. So we find that we often will try and get the patient to the treatment of their aneurysm, the one that comes first, as quickly as possible. So if we know there's an ICU challenge, sometimes that's the barrier to getting a patient into surgery, and not having coils is a barrier to getting patients coils. So if we get coils with coil free, if ICU is available, we take the patient into surgery and we clip the aneurysm. And what we have found in doing that is that the patients have excellent outcomes. So we have found that in either treatment, once we get the patient who is good grade into treatment before they have a repeat rupture, they have excellent outcomes. They come to clinic, they complain that, they hear something is happening to the hair or something else, or, they have a variety of complaints, but they are neurologically well. And the post-op follow-up studies show that aneurysms are well treated. So our outcomes have been good. But if you notice, there's a big chunk here that still says you're having bad outcomes. So one of the things that having data allows us to do is analyze where exactly that problem is coming from. And though we expect that they will have a little bit of vasospasm, we have had about 3 or 4 cases of serious vasospasm, and only 1 mortality from it in a patient that was treated with open surgery. AVM rebleeds, we have had a couple, but as you know, you have a little bit more time to deal with AVMs. But the big one is aneurysmal rebleed, something that we really should not be seeing in modern day medicine. A rebleed from a brain aneurysm that comes in good grade, and they rebleed. And it's because of the challenges that I mentioned that the patient ends up getting delayed in terms of getting treatment for factors that doctors really have no control over. And then they rebleed. And this number has gone up, unfortunately, despite all our efforts. This number is more now. So significantly, this is one of the important things. That then means that we are getting good outcome. As I presented somebody in February of this year. But in looking at the data, it's clear that getting the patient to treatment is the key to having a good outcome. Because once we get the aneurysm treated, whether it's open surgery or by coiling, they all have good outcomes. So that is our focus now, how to get timely access to treatment. And that is what we are driving towards. So we use our data to find patient-centric, value-driven care solutions for our patients. And our good overall patient outcomes. And the primary barrier or challenge that we face at this time is getting the patient to timely treatment. This is now the new goal of what we're trying to do. So we have achieved good outcomes. We know that getting the patient to treatment is the problem. Other trends that we noted in our population: high prevalence of hypertension. Every other patient is hypertensive. High levels of vessel tortuosity. I actually met some colleagues from Martinique recently, and they are noting the same things. And our colleagues in the US, like in Florida, have noted that in African descent populations, Caribbean descent populations, there's a high level of vessel tortuosity. So this is something that we certainly aim to look at more closely. There is a suggestion that we may have a slightly higher prevalence of multiple aneurysms, and the morphology of these aneurysms is they're often fairly irregular compared to what I would have seen in Canada. And then the advent of Plavix resistance, we feel that there probably is a significant prevalence of Plavix resistance. We don't really have the resources to test for it, but we think that we have seen some challenges with that, and we have had to shift our practice in terms of pharmaceuticals related to that. So just quickly looking at some of the cases we have done. This is us working in the cath lab, doing a neurointervention case or roadmap using the Philips biplane. And as you know, you can get quite a lot of information in terms of planning when you use the equipment well, measurements. You can see what the aneurysm would look like, see what a stent would look like when you put it in. These are pre-surgical images of anterior communicating artery aneurysm and post-coil embolization. This is a case that ruptured metacerebral artery aneurysm in a patient, and eventually we took that case to surgery. And this was a complex case. It had a perforator, or a branch that was stuck on the aneurysm dome. This is a small aneurysm here, and this is the MCA here and on that side. And there's something completely stuck that we could not get off. So we had to use a right angle clip and go underneath the vessel and clip the neck of the aneurysm and leave the vessel intact. And this patient came out without any issues at all. Technology allows us to treat complex lesions even in the basilar territory. It is highly complex. This picture doesn't do justice to how complex the aneurysm was and morphologically ugly. And we eventually did it. And spinal AVMs, we have had to do a few of these type of cases as well, embolization. This one is a scary one. So a massive tumor. So this is a case now where, being a neurosurgeon, you have to take it in, a full spectrum look at this case. Highly vascular, tumor, massive lesion in this. This was a young patient, 20-year-old. And with his whole life ahead of him, you have to try and do something. So we ended up doing embolization of the feeders that were possible, and it was not easy to embolize. There were en passant vessels all over, and we had to try and selectively get into each tiny pedicle to do the embolization and reduce the blood flow to that tumor. And we thought that we may have had to do a stage resection, but just because we didn't get as much embolization as we really wanted. But in the end, we got the whole tumor out in one setting with a reasonable blood loss. I think it was like 300 or 350 mils of blood loss. I think we probably did transfuse the patient because it started with a relatively low blood count, but certainly, really meticulous surgery and preoperative embolization allowed us to take on that large tumor. The patient is doing fine, doing very well post-surgery. Now over a year since the surgery was done. So the barriers continue to be the high cost of disposables. How do we get our critical care support sorted? And the staffing, the nursing staff, and it's not just nursing staff. One of the issues is administrative staff. The docs, we don't, in the developing setting, we don't really have a lot of administrative support. We don't have our own secretaries. We don't have our own administrative assistants. So it means that a lot of the paperwork you have to do yourself. If you're trying to organize around a mission, a medical mission, or any other aspect of things, a lot of it falls on you. Then you have to, after being full-fledged, trying to make sure you're on top of clinical work, surgeries, interventional room, clinics. You have to try and find a little time to do some administrative work, and that's a major challenge. So physicians' time in our setting becomes another limitation. How much time can you really dedicate to doing some of the other things that you need to do? And the key is that we have recognized that the physician leadership is important because you know exactly what your patient needs, you know what is at stake. So you have to take up the mantle of leadership in making sure that you are doing everything that you can to help your patient get the treatment that they need. International collaboration. So we have done a lot of international collaborations with various hospitals, Harvard, Cornell, Stanford, Toronto, Halifax, Vancouver, quite a number, and in the UK as well. And one of those collaborative efforts led us to a medical mission. And this mission was aimed at treating patients who we wanted to treat before, but we just never had the resources. We could never get the financing or the donations to help these patients. And the mission helped us by bringing not just experts from the Memorial Healthcare System in Florida, it also brought some necessary equipment, some onyx, and we were able to do a few cases, and it was really, really good. It also helped our local staff in seeing, treat from this perspective. So it's not just Dr. Wade saying this is what we need to do. They can see that there are other experts that come in to say, okay, yes, this is in fact what we need to do, and we all need to be moving towards this in this direction. So this is myself, and this is Dr. Ajiboye and Dr. Brandon Davis, docs from the Memorial Health System, and other parts of the team. These are all of us scrubbed into a case. This is my fellow Dr. Goodluck, really, really good doc, and one of our techs. And the nurse practitioners that came with them, Darlene and Giovanna, really instrumental, and one of our leading anesthetists, Dr. Harper Smith. You really need to have good anesthetic support, and think she and some others have been really, really helpful and pivotal to our success. This is our team debrief meeting. These are some of our residents with Dr. Davis, Dr. Goodluck, myself, Dr. Ajiboye, and some of our residents who are part of the mission. These are the heads, Dr. Bruce pictured here, and other heads which have come down to support. So you have to have good buy-in from your hospital and your colleagues to make these things happen and to move your program forward. And then a little break for the staff, after a very tough week. And then a team in tune gets the job done, So having the team, well-oiled and, working together and united will give you the best outcomes. I'd say that was one of my big take-home points, right? And obviously a happy patient here with Dr. Ajiboye, right? In true Jamaican fashion, knocking fists. All right. So our next venture will be the Caribbean Neurosciences Symposium, which takes place January 30th to February 1st. So, open invitation to anyone, and it should be good. So I hope Dr. Ali will in fact be able to come and contribute and engage with us. I think it'll be fantastic. And thanks everyone. I want to say thank you for the opportunity once more to present in this forum. We really feel privileged to represent some of the work we have done, and I think this is a great initiative.
Yeah. What a beautiful and pioneering work, and again, an inspiration as Jamaica has been in the past to all parts of the world of how to do it the way your talk structured, not only a system of things, but practically how you did things and how you started collaborations first within your hospital, then around your team, then internationally. Really, really motivating to see. Thank you for this amazing presentation. In terms of equipment needs and costs and so forth, there are some companies that have started to make low-cost coils and low-cost sort of things. I don't know if it makes much of a dent because low cost for some of the world are still high cost to other. Have you explored these different types of companies, number one? Number two, you procure these equipment and they break. So I've learned recently that there are other people just like us that believe in humanity, believe in equality, believe in access to everybody, and I met a special group of people, biomedical engineers without borders. They train people to fix equipment and to understand equipment. So there's other specialties and other parts of the workforce that do work like that. And so when you're in your theme of collaboration, I think these are the different things. So your thoughts about these lower cost equipment and how to solve the pricing issue?
Right. No, those are pertinent questions indeed. And you know, when I first returned, that was one of the first questions that we discussed with the head of surgery, especially. We had a long discussion about it and where we would look if we were to consider finding lower cost equipment. One of the challenges I first expressed was, you know, these items don't know, you know, in the US, for example, you can rely on the US system somewhat. I mean, no system is perfect, but I think it's fairly robust. You have to go through clinical trials, you know, you have to, there's a stepwise, there's a pretty robust system of how to assess products before they're deemed to be safe to be used or released to the patient. And that system, I think, is really, really important to protect the patient, you know, from, you know, any inferior products or, you know, to pose any safety challenges or complications related to your procedure. And I can tell you one of the issues we had when we used material, I can't remember from which manufacturer, we were using a catheter for a procedure, and the tip of the catheter was in the common carotid artery, and it just broke off. You know, not particularly tortuous. The tip just broke off, like 2 pieces of it just went and lodged at the carotid bifurcation, and I'd never seen that before. And so, you know, literally, I don't think we even had a proper snare device. I had to borrow one from the interventional radiologist to go in there, snare it, and drag it all the way down and out. In the end, we could not even get it out through the sheath. It ended up going down distally into the distal leg arteries where it lodged. Unfortunately, the patient had no ischemic problems whatsoever. It was completely asymptomatic, but I'm just glad it didn't go up in the brain. And, you know, and that was a powerful lesson for us. And, you know, and there's some other equipments that we have looked at. And, you know, the issue is always, even if you think anecdotally, you're looking at it, you're trying to evaluate it, that it's safe or that it's, you know, how do you know for sure? Because I don't think many other places have as robust evaluations as you have in the US and UK and, you know, North America and the United Kingdom. So that was one of the challenges, that though the products may be lower cost, how do you really know for sure that they are going to be safe to use? But we have explored the idea, and because of some of those challenges, you know, I've kind of shied away as a leader in the endovascular, to kind of shied away from it somewhat, because I'm a bit concerned that some of the few things that I've considered to use or tried, we have had, you know, they have had fragmentation or some other issue with the equipment. Something as simple as a stopcock. I remember, you know, they were trying to cut costs. The hospital, you know, I'm not part of that process for some of the basic items, but I noticed that one of the stopcocks would simply disconnect from the catheter while you're doing a procedure. So, you know, the risk of embolization and all of these issues. And you're operating, and then you realize that for whatever reason, you're having a lot of blood coming back in your line. And when you look, it's disconnected or it's loose. And literally, you know, you take up the stopcock and it comes apart in your hand, you know, then that's a big safety problem. So then you know, you flush, you double flush, you clean everything up, you do an angiogram, you look, everything is fine, everything looks good. But then, you know, you have to throw that entire back, you have to call the you know. So so therein lies the issue. And then when they got a a better branded item, it worked just fine. So that's one of the challenges we have. How do we access cheaper equipment, but at the same time guarantee patient safety?
Yes.
So
I
that's
think
the challenge.
there may be an opportunity there. So this has turned out to be just an immense meeting with wonderful presentations. Thank you all for coming up. We're hosting a conference in Boston. This group is going to be part of this on April 23rd and 24th, and we'll send sort of an invitation out shortly. But Dr. Lanzino, any final words and thoughts?
Well, I am both inspired and humbled at the same time. Humbled because I realize how little I'm doing compared to the gigantic effort the colleagues have shared with us. It has been really a great morning, very nice presentations, and definitely a lot of work to do, but the three presentations have shown us really gave us a positive overview despite incredible challenges, and an example on how the world, despite the realities that go on in normal life across the world, but medically speaking, the world is coming closer and closer together. And the same procedures that we do every day here in the United States, they are available in many other parts of the world, despite some challenges. But at the same time, there are great opportunities, especially when you have the chance to start from scratch. So really inspirational. I like to thank the speakers, like to thank the participants, and also thank you to Imadullah and Johan Alexander that have helped making this possible. Thank you, everybody.
Thank you so much.
Thank you.
Thank you.
Thank you.
Bye.
Bye.